intestinal lectures. So starting with anorexia. This is a lack or loss of appetite for food. Now it's very common sign and symptom for anyone with major stomach aches or even disease of the bowel. Next is echolalia, where the muscles in the lower part of the esophagus fail to relax, preventing food from passing into the stomach. Now it's very common in pediatric populations. The next term is pretty difficult to pronounce. Cachexia is where we have severe weakness and wasting of the body due to chronic illness. Next is dysphagia, swallowing difficulties, not to be confused with dysplasia, the abnormal development of cells with inside tissues and organs. So think dysphagia has a G, relating to the GI tract in dysphagia, having to do with difficulty swallowing with dysphagia. Okay, next is volvus, the twisting of the intestines, resulting in a bowel obstruction. Now, hematochezia is where we have blood in the stool. But be sure to write this next part down. For a low bleed in the rectum, we have bright red blood. And for a high bleed high up inside the intestines, this is known as dark tarry stools, called melena. So please be sure to write this down. I made sure to highlight it for you. As blood is digested in the intestines, it turns it into this dark coffee ground looking substance. So just know that this is melena from this digested blood. Next is hematemesis, blood in the emesis, basically blood and vomiting. So we also get coffee ground color that is brown granular material from digested blood. And HCl acid is acting on the hemoglobin. This is why we have that coffee ground color. And for bright red blood, this is an active hemorrhage. Basically, the stomach hasn't had a chance to digest the blood, so this is how we know that it's an active, ongoing hemorrhage, or basically active bleed. Now next we have malabsorption, the inability to absorb nutrients from certain foods. For example, this is lactose intolerant clients with a dairy intolerance, or celiac disease who are gluten intolerant. Next is megacolon, the abnormal dilation of the colon with abdominal distension. Very, very painful. Next is liver labs, the very important for clients with liver disease like cirrhosis and hepatitis. So you must know the ABCs of the liver. So the liver produces A for albumin, 3.5 to 5.0. So you must know these key numbers as it's the top tested. Now B is for bilirubin, C is for clotting factors, and the two liver enzymes to know is ALT and AST. When the liver cells are damaged, they release ALT into the bloodstream. So an ALT test measures the amount of ALT in the blood. So just think ALT is all about the liver. So let's dive into all the key points from our cirrhosis video. Simply think the liver produces ABC. A for albumin, B for bile, and C for clotting factors. So starting with albumin. Albumin is a protein inside the blood that does three things. It transports drugs inside the body, it also attracts water to keep it inside the vascular space, and also binds with calcium to make bones strong. So just think albumin attracts water as well as attracts drugs and binds with calcium. Now, another memory trick that I personally used during nursing school is to think of albumin as Al Pacino from that movie Scarface, for scarosis. Now, Scarface is an old movie from the 80s about a drug lord who transports drugs, and he's near Miami, basically near the water, to help you remind me of water. So just think here, when the liver fails in scarosis, the body can't produce albumin, so we get hypoalbuminemia. So drugs don't get transported properly, and water builds up inside the body because albumin isn't there to attract the water. And this causes edema and third spacing, like ascites, where the abdomen is filled with fluid. So just think of the double A's. Ascites is for abdominal fluid. And lastly, hypoalbuminemia, we see low calcium inside the blood due to low binding.
So we see weak bones with the big risk for fractures and even osteoporosis, those porous bones. And lastly, the two classic signs of hypocalcemia, or basically low calcium, is Trousseau's. We have an arm twerk with a blood pressure cuff on, and also Chvostek's, which is a smile when you stroke the side of the cheek. The next thing is B for bile, which we call the bile bus, helping to scoop up excess cholesterol and bilirubin, taking it from the body and into the potty via the bowels. Now, cholesterol, as you know, are those lipids that clog the arteries if we have too much, leading to major cardiac issues. And bilirubin is just those dead RBCs, or basically red blood cells. So when the liver fails, then we get a buildup of both, high cholesterol and high bilirubin, which bilirubin turns the body jaundice, making the entire body yellow. So we get yellow skin, yellow eyes, specifically the white part of the eye, called the sclera. So Kaplan mentions cirrhosis. Expected laboratory results is elevated bilirubin. And this is due to the lack of bile, or the bile bus, to help carry this bilirubin out of the body and into the potty. The last letter in our ABCs is C for clotting factors, or coagulation factors, which helps the blood to clot. So with liver disease, the blood doesn't clot fast enough, leading to huge bleed risks. Always our number one concern is bleeding. So naturally, we see longer clotting times, resulting in longer coagulation times on the coagulation panel when we look at lab results. So Hesse mentions, which complication is a patient with cirrhosis at risk for? And the answer is bleeding. And another question, which hematological symptoms might be noted in a patient with cirrhosis of the liver? Select all that apply here. Anemia, low blood volume, leukopenia, low white blood cells, and a big one here, thrombocytopenia, low platelets under 150,000.
Now, moving on to the pancreas. This releases certain enzymes to break down food so that the GI tract can absorb the nutrients. So the main enzymes to know for exams is serum amylase. This is an enzyme for protein breakdown. And serum lipase. This is an enzyme for fat breakdown. So just think amylase and lipase tests are used to detect pancreatitis. The test measures the amount of enzymes circulating in the bloodstream. Next is H. pylori. Now this is a causative bacteria that leads to PUD, the peptic ulcer disease, and gastritis. As the protective lining in the stomach, the gastric mucosa, is destroyed, which wreaks havoc on the GI tract. Alright, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free Appendicitis is the inflammation of the appendix, which is a small finger-like sac of tissue located in the first part of the colon, in the right lower abdomen, also called the right lower quadrant. So write that down. You must know this. It often gets obstructed by fecal matter, which leads to inflammation and infection. So the key sign and symptoms to write down is fever that is low grade, and the biggest sign by far here is right lower quadrant pain with key term rebound tenderness. So write that down. It's always on exams. You might even see pain between the right hip area and belly button. This is technically the right lower quadrant area, also called the umbilicus area. Now this area is referred to as McBurney's point. So again, write down these key terms. Exams in the NCLEX love to ask you about these key signs. Many exams will say it in a different way, but always look for the key term, right lower quadrant pain, and just think the appendix is right here. So don't let the NCLEX trick you here. It's not left upper quadrant pain radiating to the back. That's typical of pancreatitis. And it's not right upper quadrant pain radiating to the shoulder. That's typical of cholecystitis, that gallbladder inflammation. So just think, the right lower quadrant, the appendix, is right here with rebound tenderness. So a common NCLEX question, what is the typical pain presentation of a client with appendicitis?
So option 1, the pain starts in the left side below the belly button. No, it's right lower quadrant. The pain is diffused all over the abdomen. Nope, right lower quadrant we're looking for. How about option 3? The pain starts in the left. No, left. It's not the left, it's the right. And option 4, the pain starts around the umbilicus. Okay, that's the belly button area. And then moves to the right lower quadrant. Yes, always look for that key term, right lower quadrant. Now, in terms of complications, the most deadly is a ruptured appendix. Basically, an explosion of the appendix, and all that infection pours into the abdomen. This is called perforation. So just think peritonitis is the medical emergency. Very, very deadly. So the NCLEX tips, write these down. High fever, tachycardia, tachypnea, fancy words for a fast heart rate and a fast respiratory rate, as well as key terms, a rigid board-like abdomen, as well as rebound tenderness. So we must avoid anything that can increase blood flow to the intestines. So the key term here is no heating pad or even a heating blanket. I would write this one down and highlight it. This guy came up a lot on NCLEX questions as to what to avoid for acute appendicitis. Now, we also avoid anything that can add pressure into the abdomen. So no laxatives and no enemas. Again, we want to avoid any added pressure into the bowels to avoid rupturing that appendix. So the top miss NCLEX question here. A client with appendicitis suddenly develops tachycardia and tachypnea with a high fever. Which interventions would have the highest priority? Select all that apply. So we want to call the surgeon as the appendix may have perforated. Next, we give IV normal saline to prevent hypotension. And lastly, maintain NPO status, since the client will have to go to surgery immediately. So I would recommend writing these down and knowing them for the highest priorities for appendicitis rupture. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. Now for celiac disease. This is an autoimmune disorder which causes the body to react adversely to gluten, a common protein found in whole wheat, grains, and even beer, as well as rye and barley. Basically any wheat-based product. So write this down. Dinner rolls, breaded meats, and even spaghetti. So Hesse mentions, which meal ordered by a patient with a new diagnosis of celiac disease indicates a need for further dietary instruction? Spaghetti with meat sauce and whole wheat noodles. Yes, the key term here is whole wheat. Now the pathophysiology is pretty simple here. When gluten is eaten, it leads to inflammation that damages the intestinal mucosal and prevents absorption of nutrients. The key hallmark is the absence of intestinal villi. Normally we find curvy folds inside the intestines that help to absorb nutrients. But in celiac disease, we find a loss of these folds, resulting in further loss of surface area and a malabsorption of fats. So children with celiac disease usually have a stunted growth or slowed growth. So the key signs and symptoms are diarrhea, staturia, which is fatty stools as fats are not absorbed in the body, as well as abdominal pain and even weight loss, as well as stunted growth and delayed puberty in children. So the key education to write down here is fat-soluble vitamins, as nutrients are not easily absorbed. And these include vitamin A, D, E, and K. So the memory trick we use is think of a bunch of fat guys playing with a deck of cards. So a deck of cards will help you to remember that fat-soluble vitamins are A deck, vitamin A, D, E, and K. Now lastly, there's no cure for this condition, and it's a lifelong gluten-free diet. That is necessary. So gluten-free foods, or anything without a wheat base. So remember, plain meats like fish, beef, chicken, or turkey that are not breaded, and grains like rice, corn, potatoes, and even soy and quinoa are actually okay, as well as nuts, beans, and legumes, and fruits and veggies are okay. Remember, the key term here is a wheat-based product. So gluten-free basically means wheat-free. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the Now for GI cancers. In this video, we're covering the key points for esophageal cancer, as well as colon and colorectal cancer. So starting with esophageal cancer, this is when there's cancer within the esophagus, the food tube, that takes food from the mouth and into the stomach. So the key point is the risk factors. So write this down. Acid reflux or GERD that goes untreated for years ends up scarring and destroying the esophagus lining, leading to Barrett's esophagus. Basically, a thick, red, destroyed esophagus. So write that down. Commonly tested is acid reflux as a big cause for esophageal cancer. And for the other common risk factors, just think OAT here. O for obesity, or a BMI over 30, A for alcohol, as well as T for tobacco, including smoking and chewing tobacco. Now switching gears to colon and colorectal cancer, or cancer of the colon. This includes the large intestine and the rectum, that exit door of the GI tract. So the main risk factors include diverticulosis and ulcerative colitis that is long-term. So just think anything that causes destruction, just like esophageal cancer with that GERD. So diverticulosis is that little outpouching pockets all over the large intestine, which can lead to flare-ups and inflammation called diverticulitis. Now ulcerative colitis that is long-term, this includes open sores all over the large intestine, resulting in bloody stools during flare-ups. Now these two conditions cause destruction of that large intestine here, leading to a high risk for colon cancer. So the HESI mentions, which disorder does the nurse suspect in an elderly patient with a history of diverticulosis who reports rectal bleeding? The correct option, colon cancer. Now another risk factor is family history of colorectal cancer. So family is a big factor that's commonly tested, specifically for colorectal cancer here. And the other risk factors is OAT. O for obesity, that BMI over 30, A for alcohol, and T for tobacco. So we included cigars here because it's cigarettes, cigars, and even chewing tobacco. Now for the signs and symptoms of colorectal cancer here. Number 1 is unexplained weight loss. Huge NCLEX tip. I would write that down. And we also have the ABCs here. A for abdominal pain, B for bleeding. Key terms is blood and stool, as well as low hemoglobin. And C is for change in bowel habits. So write these down. These are commonly tested for colorectal cancer. So when you get a question about a client with a family history of colorectal cancer with unexplained weight loss here, key term, and a change in bowel habits, and a hemoglobin value of 9 when compared to 14 just 12 months earlier, which diagnostic test is expected? We must expect a colonoscopy to check for that colon cancer, since all high risk factors are for colon cancer here. Now, speaking of diagnostics, a colonoscopy, we're just sticking a scope up the butt, or the rectum, I should say, to check out the colon. So let the name help you here. Colonoscopy, we're just scoping out the colon here. Specifically in colorectal cancer, we're scoping out for tumors or even polyps that may be cancerous. Now, colonoscopy is also used in other GI issues, like ulcerative colitis and even Crohn's disease, to scope out the colon there. Now, there are some key interventions before and after a colonoscopy. So before, we do clear liquid diet with laxatives. And we give the patient a big, huge jug of polyethylene glycol. Brand name is Go Lightly. This huge jug of liquid helps to clear the bowel and allow the scope to take a good look. And lastly, NPO after midnight before the procedure. Now, after the procedure, it's priority to monitor for perforated bowel with peritonitis. This is a medical emergency. It's very deadly. So write down these key terms here: fever, tachycardia with tachypnea, abdominal distension, and a rigid board-like abdomen. Write that one down. Huge NCLEX tips here. We must report any of these findings to the HCP immediately. Trust me, this has been tested multiple times in various question banks. Now, for key teaching after the procedure, we recommend a high-fiber diet. And for some reason, the key term cabbage came up on a lot of question banks. And we use the acronym OAT. O for obesity, we teach the patient to lose weight. A for alcohol, we have them stop or reduce. And T for tobacco, we use smoking cessation here. So Kaplan mentions dietary alterations for a client with a family history of colorectal cancer. Add key term cabbage to the diet to reduce the risk of colorectal cancer. And lastly, an interesting question from Hesse here. The nurse is caring for a patient with cancer of the small intestines. That required the removal of the duodenum and jejunum, basically just two parts of the small intestine here. The nurse knows that the patient will have difficulties with which physiological process? And the answer is digestion. Well, obviously, guys, if you're removing part of any part of the intestine, naturally we're going to have digestion issues. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate and even your Constipation is our next topic. Now, this lecture was really hard to get out. As you know, it's the inability to poop, or in fancier terms, infrequent bowel movements, or difficult of passing stools that persists for about several weeks or longer. So the signs and symptoms: passing fewer than 3 stools per week, or having lumpy, hard stools, and even straining to have a bowel movement. Now, in terms of the causes, this includes stress as well as low fluids and low fiber. So be sure to write down the double F's. We basically don't have enough fruits, veggies, or whole grains in the diet, or even too much fiber without adequate fluid intake. You see, fiber can cause constipation if not taken with fluid, since fiber only inflates with fluid to scrub the GI. So too much fiber without proper fluid intake can actually cause constipation. Now, in terms of treatments, high fiber and fluid with ambulation. This is always key on a lot of exams. So Hesse mentions, which suggestion of the nurse helps the child in relieving constipation? You should eat a high fiber diet. And question number 2. A mother of a 4-year-old reports that her child has hard and dry stools. She reports a diet high in whole milk, processed meats, bananas, and macaroni and cheese. What is the nurse's best reply? Try replacing macaroni with whole wheat macaroni. Yes, the key term there is whole wheat. It has a lot of high fiber. Now, in terms of complications, a really interesting one is fecal incontinence, also called encopresis. It's a condition in which a child resists having bowel movements, causing impacted stool collection inside the colon and rectum, which eventually leads to leakage. So 3 steps to treat. Number 1 is laxatives and stool softeners. Number 2 is that fluid and fiber. And number 3 is to change the habits. So key terms to write down here. We always schedule regular toilet visits after meals. The key term there is after meals. And keep a diary for toilet sessions. And a big one here is reward system for effort. Huge NCLEX tip. And not rewarding for each bowel movement. So don't let the NCLEX trick you here. We reward for effort and participation, not necessarily for success. So Hesse mentions, which is most associated with a child with fecal impaction? Encopresis. Yes. Just think that the child is keeping all that stool in within copresis or encopresis. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos.